Let me put it this way. Prof stayed at my house, so my brain is overloaded. And I think we can learn so much. Like what I realize now is this is a man with 1,000 hats on. Which one do you pick? Now, I'm fortunate enough, and I think, to be in the same situation. How do you think this? Okay. I also carry two hats. I'm also a physician in interventional pain, where we use a lot of these drugs that we use for sedation, like ketamine, for pain infusions, and also radio frequency work. And the bottom line is, after speaking last night to Dr. Pillay, I realized that we don't need drugs to treat dis-ease. The problem is in our genome, that we don't realize that we were fooled by a lot of these things. Now, what do we do if we sedate patients? Very controversial now, but what do we do? He made a comment last night that part of what we do is increasing people's moods. And what drugs do they use? Yeah, we know about ketamine. And then he said, and what about ketofol? How does our patients respond after a sedation? How many of us actually evaluate this beforehand and afterwards? It opens a new field of research, and it makes me excited to think of how we can actually change the mind. Now, if you think about it, I've just got to get my mind. What we do whenever we start playing with chemicals is we influence this sensors up here. And we know this thing is controlled by our environment. It's controlled by how we think about things. Do you realize that there is no such thing as pain? Pain is a perception of a reaction to our environment. If I tell you, you're stupid, you're ugly, you're useless, and I do it enough, I'll probably be successful to convince you that you will believe it and start acting accordingly. We all know the story that you can blow off a person's leg and he can still run till he gets to safety. So the thing is, if I can program your mind to, is this danger to me or is it safety to me, you will act differently. Very interesting concepts. This was the talk last night, so I'm diverting now. But if you think about it, ketamine is an NMDA agonist. Where's the most receptors in the body? Yeah? Sorry? In the spinal cord. Where do we work when we do anesthetics? Mostly spinal cord or top here. Right, so we influence certain reactions. Think about what that reaction is if there's no brain. Does an anesthetic block a spinal reflex? No. So if a patient moves, does it mean that the patient feels pain? No. Right, because the brain doesn't tell the person, or it's not programmed at that moment to tell you there's danger in you. It's just a reflex. So maybe if we just start thinking differently, and this was the talk with Dr. Pillay last night, if we start thinking differently about what we do. So I want to start my talk by asking, what do we do when we do anesthetics and sedation? It's not a trick question. Come on. What do we do? Why do we do what we do? Very philosophical question, isn't it? And I've got the whole audience. So this is an ethical lesson that I realized that we are just part of a team, a bigger picture. And our biggest function is actually to make the surgeons look good. Isn't that so? Any surgeons in the room? I'll say it again. Our function is to make our surgeons look good. Right. Because we can have the most successful procedures, and if a patient wake up with a bad experience post-op, and what's the two biggest things post-op that patients hate?
Pain.
Sorry?
Pain and vomiting.
Pain and vomiting. You will have a bad experience, bad surgeon, bad surgery. And who's the bad guy, the surgeon or you? Or the patient or the drugs? Who do we blame? So I want to start from that point of view and say, I've come a long way in sedations. I've had the fortunate opportunity of being a shadow of Prof, and he allowed us a lot to do in the last 23 years. I've seen the evolution of sedation, and what I do now is things that I wouldn't have done 5 years ago. And we're still learning about this. But here's the new generation. This room should be 10 times the size that we're doing right now. Because we're going to move, I'm going to make a statement that we're going to move away from anesthesia as we know it today to total intravenous anesthesia. Because that's the safest route that we can do it. We know it already. But it's not part of our genome yet. Okay, so how are you going to change your environment to adapt to what Prof. Pillay just said? So thanks for setting me up for this talk. Okay, right. So just by definitions, the goals are most common post-op complications, the sedation phases, and I just want to try and leave a few ideas with you. The definition starts when we end the procedure, but that's a new phase that starts, and it doesn't mean it's the end of your procedure, right? It's actually the beginning of the end of a procedure, all right? So it starts with the end of the procedure, you're recovering until the patient goes home. It stays your responsibility, right? And the goals of this is, and by the way, I've got to put a disclaimer in, my slides doesn't look as attractive as Cherie's. I just passed PowerPoint 101, hardly. Okay, so we want to get the patient back to a pre-sedation state. We want to get rid of the residual troublesome sedation effects, the nausea, vomiting, pain, bleeding stuff, and make sure that the patient are prepared or be ready to be discharged. All right, how are we going to do that? The most common post-op complication? Any suggestions?
Sleepiness.
Any other suggestions? What's the most dangerous? No, let me rephrase. What's the most dangerous post-op complication? All right. So we're going to divide it into two groups, patient-orientated and equipment-orientated. But like you said, the most common patient-orientated one is hypoxia. And again, hypoxia is a symptom. What is the cause of it? A lot of the time, the nursing staff will tell you, doctor, the patient's SATS is falling, and you will ask why, and it might just be from a loose probe. So the question is, let people start thinking differently about what's going on in their environment. Okay, what's the cause? Is it an airway obstruction, hyperventilation, apnea? Is it a central effect of your drugs? What is the cause? Don't tell me the symptom, tell me the cause. Right, so our first post-op complication that we should be aware of is the respiratory system. It's also, intraoperatively, also our number one challenge as far as sedation is concerned. All right, basically I've used two articles that you can go and watch later on and the guidelines as references. And the second one is second most dangerous stuff that we can find post-op. Oversedation will cause what? All right, cardiovascular, hypotension, and that's normally drug-related. So what do you use in your drug regime? Because that will influence your post-op complications. Right, arrhythmias is fortunately very rare, but if it does happen, it's very it gives me arrhythmias, okay? And then, thirdly, our metabolic stuff, hypo and hyperglycemia. Hypothermia is quite common, especially with kids and older people. Electrolyte imbalances. Remember, a lot of your patients are nil per mouth for a long period of time. And then lastly, your diverse symptoms of nausea and vomiting. And again, remember, that's the symptom. What's the cause? So a lot of the time, we think about stuff like electrolyte disturbances, but remember, hypoglycemia can also present with this. All right. So make sure that your patient gets something to eat as soon as possible. Yeah, a lot of the time, that's all that's needed. Okay. Dizziness, shivering, bleeding, and pain control. Now, this is the common stuff, and we sometimes overlook the common stuff. The basics stays the basics. Right. Equipment. I'm just quickly go through this. Our recovery room is basically our default, but we don't always have a recovery room facility if we work doing primary sedations, if we work remotely with a dentist or in a remote sedation room. So the things that we need to focus on is the team. Is your team equipped, experienced to handle complications remotely? Your setting, your facility. A lot of the time, if we do dental sedation, the dental chair is also your recovery place. Is this a convenient place, or does the next patient need to come out and you need to whip this patient out into the waiting room? Your patient profile, how do you select your patients? And one of the most important things that we probably should do is first, pick your patient and pick your surgeon before you start a procedure. You are the weakest link, and if your surgeon can't accommodate you, you're going to have trouble. And then you might as well quit up front. All right, so patient profile is a status, and then the sedation technique, your regimes. Are you going to use midazolam? Are you going to use an opioid? What analgesia, dissociative drugs? Is ketamine indicated, contraindicated, and so forth? Right, so it's not just straightforward. And the appraisal and accreditation. Just remember, this becomes a medically legal point. The first thing that we're going to do in a court of law is ask two things. What's your qualification? What's your experience? And if the answer is negative on that, I will stand back and say, settle outside of court. This person is guilty. So please, go the extra step. The accreditation is not that difficult, but it will bail you out in most of the cases, so please. Right, equipment, let's go. The recovery room, is there a dedicated space? Is there enough time to recover a patient in that space where you need to be? For instance, if it's the dental chair, is the next patient waiting outside, or do you have time? You've got to plan these things up front, and that's why, like Andy said, you've got to know the places where you work, especially if it's remotely. And if you work with a dentist the first time, it's a good idea to go and visit the facilities beforehand. Tell him up front what's possible, what's not possible. Get an idea what is his needs and wants. Because some people think that if you do a sedation, please knock me out. It's not possible. If you're going to inject a child, he will move unless you do a deep sedation. Is that the right child to do a deep sedation? Because you can't do deep sedations in all children. All right. Is the staff trained and experienced? And 9 out of 10 times, we are the recovery staff. Am I equipped to recover the patient? Hopefully, yes. But in certain cases, I have to leave a patient in the hands of an assistant so that I can start the next case or put up the next drip. All right. So make sure that your staff is trained. And then the sufficient equipment. Somebody spoke about the soap. Now, Dr. Google is a nice thing. I actually, while sitting here and the person asked, I thought maybe I should just Google it quickly. The suction, what type of suctions do you have? Do you have the right equipment there, the right suction tips for pediatric cases or a Jaeger for adults? What do you do if there's load shedding? Is your suction going to work? Are you prepared for it? Okay, oxygen, all the oxygen equipment, not just the oxygen cylinder, is it working? The different mask, is the tubes working? Do you have nasal prongs or an oxygen mask? The different airways that you need. Sorry. All right. The airways, do you have ET tubes, different ET tube sizes? Do you have an LMA available? Those things are something that technically a lawyer will take you out if you don't have it. So please check these things at least once a year. I basically, end of every year, I just go through all my resuscitation medication because they do expire. And we never use them. We hopefully shouldn't use them, but if not, you're going to be... Jy gaan spyt wees as jy dit nie reg doen nie. You're positioning a patient, very important. Sometimes the dentist wants stuff in different positions. Ask your patient beforehand, on how many pillows do you sleep? Are you comfortable on lying back? Some people get claustrophobic if they lie back. This is your personal space. If you look up and all you see is the dentist up front or above you, people get claustrophobic and they become anxious. So if you don't inquire about it, you're going to find out the hard way during the procedure. All right. The position, our monitoring equipment. The standard stuff still stays standard, but make sure it works. I've recently started experimenting with BIS monitors. Guys, it's going to change our way we practice. We over-sedate all our patients. And by the way, if you do an induction, watch your BIS monitor and see how many times you get burst suppression. It's scary that about 100% of what we do actually goes into burst suppression. Flat lines, yes. Okay, and then continuous monitoring afterwards becomes vitally important. So please, these things, it's got to be in the back of our heads always. Right. Spoken about that. The patient group. This is normally the patients just that can make the world difficult for us. Our extreme ages, small children. In sedation, we normally talk about 3 years old. I've done them as young as 18 months. But if you haven't got experience with it, please don't do it. Select your place. Make sure that your environment is conducive to the challenges that you might have. Generic variations, your mentally retarded, Down syndromes, these kids that Chris Kay would do. Be careful that you have the right, or make sure that you are equipped and trained for these people, the right genders. The most difficult sedations, as far as I'm concerned, is young teenage girls. I don't know if it's the hormones playing up with the medications, but they can be notorious for being difficult cases. Our body type of patients, the guy with a short, stiff neck that can't put his chin on his chest, or you can't move, or the older people that can't turn their head, the Down syndromes, the obese patient, the obstructive sleep apnea patients. We can do a whole lecture on that. And they can be done, but you have a challenge at hand. There are means and ways to deal with them, but make sure that you have the right experience, right equipment, right place to do it again. Comorbidities, like I said, cognitive dysfunctions. We often are asked to do this so-called mentally retarded kids or people in the dental chair. And boy, oh boy, have I been caught out with people who get locked jaws. Okay. Make sure that you can handle it. What do you do when a patient doesn't open his mouth? Are you going to put him deep? Increase the risks? Or how are you going to deal with it? Be prepared, have a plan. Your post-operative pain, most of us, once you do local anesthetic, you can do just about anything. Knee replacement, hip replacement, whatever, under sedation. So what's your post-operative thing? Remifentanil, as far as I'm concerned, is the ideal sedation drug. And I did it once, and I phoned Prof way back, I think 2006, and he said, "You're going to kill somebody." I said, "But it's got all the right characteristics, short acting, it's eliminated, whatever." Any case, cut a long story short, the problem with remifentanil is if we don't give something for pain, post-op management, you're going to run into a patient that wakes up with pain. Right, so how long does it take for morphine to kick in? IM. At least 40 minutes before the time, before you switch off your Remi, you should have your morphine on board already. How long does it take for Sufenta to work IV? 5 to 6 minutes. Right, so if you start your pump with Sufenta and the guy goes for giving a local anesthetic or whatever, boy oh boy, you haven't got pain relief on board. Right, so let's start thinking a bit what we're doing. Metabolic causes, your uncontrolled diabetes, chronic drug use. What's the drug interactions? Because that will have an effect on how our patients wake up post-op. Right, as a pilot, we like checklists. There's a pre-flight checklist before you take off, during flight, before you come and land, whatever. So the same thing is start planning your post-op recovery pre-op. This is all, well, I think Cherie's actually said it. It's how we manage, how we plan our procedure which will make it successful. If you fail to plan, you plan to fail. Right. So in the guidelines, there's nice checklists. What questions do you need to ask beforehand? For instance, if you don't inquire about a sleeping apnea or a positive a CPAP machine, patients don't give it spontaneously. Ag, ek gebruik 'n ou bloeddrukpilletjie, dokter. And if you don't know what it is, you can miss it. That there might be something that's going to interact with your drugs. How many times do we find these kids with ADHD? And they're notorious for being on drugs that interact with our sedation drugs. Seroquel, bad drug. Okay, but you've got to inquire about it. No, ek is op 'n antidepressant, dokter. Ask for these things, okay. So there's a whole list of things that we can ask for. Previous failed sedations, renal functions. People don't see it as, ag, hoë bloeddruk is niks ernstigs, it's nie 'n hartsiekte nie. Right, but it doesn't tell you that he's been last week in ICU for a AF cardioversion or stuff like that. All right, so check these things. What pre-med are you going to prescribe? When are you going to prescribe it? I still like the clonidine story, so yeah, let's move on. The immediate post phase, remember the moment the surgeon stopped the stimulation, your patient can actually slide into a deep sedation. That's when the trouble starts. Then you should be more vigilant than ever before as far as monitoring is concerned. So your monitoring should be the same as intraoperatively. Don't leave your patient alone. Don't turn your back on a patient, especially kids. Right? They hear you talk, they want to move, and the next moment they're on the floor with their more teeth out. So observe, observe, observe. Right, the emergence phase, we often see this, the excitatory phase or agitation or delirium post our procedures. And especially in kids with midazolam, who's got that paradoxical reaction, it's very unfair to give a kid like that to a parent and say, go home. Like, kids will break down your car. So take out your flumazenil. It's an expensive exercise, but damn it, have a good reputation. Those patients go walk and they will tell people how bad they experienced sedation. It wasn't the sedation, it's your technique that was wrong. All right. Your timing characteristics of the emergency phase is dependent on a number of variables, your drug regimes. Did you titrate your drugs? Do you actually taper your drugs off towards the end? Unfortunately, in dental cases, we sometimes wait till the last bit before we take or do the extraction. So that's when you make them deep. But it will also take longer to recover then. So plan your sedation, your titration. Airway complications, like I say, laryngospasm, we should never see it because our patients should never be that deep. But it happens. Have you ever tried to swallow with an open mouth? It becomes difficult. For a sedated patient, even more so if you suppress the reflexes. So be aware of these things that can happen. Lastly, our discharge phase. The guideline states two systems that we can use, the modified Aldrete scoring system and the modified post-anesthetic discharge scores. No, these systems are not foolproof. They weren't designed for procedural sedation or for ambulatory sedation necessarily. So use your common sense. Peter said if a person can walk out the door, he should be fine. If he can talk, he should be fine. But remember, it's because we stimulate them. If you have drugs on board with a long action, like for instance dexmedetomidine, that patient can fall back into sleep position. So somebody still needs to observe him. Please make sure that pre-op you ask the patient that there's got to be reliable transport, not an Uber. We are medically, legally obliged to make sure that the patient is safe. So there's the Aldrete score, level of consciousness, oxygen saturation, our circulation vitals, movement and activity in respiratory systems. And then the other things, post-op nausea and vomiting pain. Okay, and then let's close off. It's no longer necessary that a patient can take fluids, oral fluids, but watch the type of procedure that you do. For instance, if I do rhizotomies, one of the things that I want to know is that my patient can control his bladder. So that still stays a criteria for me. Right, must be accompanied by a responsible person. Written post-op instructions, make sure that you've given him a telephone number where to get hold of you, and if he can't get hold of you, the surgeon or whoever. Right. Emphasize medical legal implications. For 24 hours by law, you're not allowed to drive or operate heavy machinery. So, I mean, flipping hell, if I do have a sedation today, I can't fly tomorrow morning. Okay. We see it quite often with pilots, and make sure those guys, please write them that sick note for 24 hours. Right. Hide the credit cards. Okay. And if you didn't write it, you didn't do it. The guidelines still stays our goal to where we will go. So if there's a problem, that's what we're going to measure you against. Thank you.
Thank you, Chris. We don't have much time, but one question there.
Just a comment, something that we've added to our anesthetic consent form in the things that you shouldn't do after receiving an anesthetic is be the sole care provider for small children and utilize social media.
That's very important. Thank you.
Thank you, guys.